Well, good morning, good afternoon, good evening, everyone, and welcome to our second in the series of the Global Dermato-Epidemiology Forum Seminar Series. My name's Rod Hay, and we have two great speakers today who are going to approach the thorny issue of how one sets about measuring disease burden in skin disease. And it gives me great pleasure to introduce our first speaker, Dr. Katrina Abubara from UCSF. She has huge expertise in this area, particularly focusing on inflammatory skin disease. And so she's going to start off by talking about measuring skin disease incidence, prevalence, and burden, and the trade-offs between the different methods. Katrina, over to you.
There we are. Can you all hear me now?
Yes.
Good morning. Thank you very much for the invitation to be here. I'm delighted to speak to you all today. And I'm going to mention my disclosures, none of which are pertinent to this presentation. First, I'm going to talk about challenges and opportunities for skin disease measurement. I'll talk a lot about data sources and how those affect our measurement, including routinely captured data, which is increasingly prevalent, and give you some ideas for the future from my humble opinion as a dermatologist and an epidemiologist who studies primarily inflammatory skin disease in the US. So I will stick to what I know and have a lot of examples from that perspective, but hopefully this will stimulate conversation and be relevant for many of the other important infectious and cancer as outcomes that affect our patients. So the opportunity is that we can see the skin. We can make diagnosis just by looking at it. Patients can also report on their symptoms. This is different from a lot of the other organs. Patients can't always tell you how their kidney is feeling. And it's very accessible for sampling. We don't have to do a craniotomy and a brain biopsy to get information. So there's a great deal of opportunity for measurement. However, the challenge is that the ease of visual diagnosis means that we've come up with very general disease categories. So, for example, from the internet, one could differentiate between eczema and psoriasis just by looking at this cartoon with some degree of certainty. Uh, if we were studying something like the heart, for example, that's less accessible, this is a recent figure from a Nature publication looking at all the different types of sensors, wearable sensors that are available to measure heart disease. You could imagine that you end up with a lot more detailed, quantitative, nuanced data that we don't get for skin disease because we can see it. Patients also self-diagnose and treat skin disease, so that it may be more challenging to capture those types of conditions rather than those that always show up in a hospital or emergency room. So thinking about incidence, prevalence, mortality, morbidity, sometimes there's the idea of the epidemiologist bathtub, and disease incidence being what's going in, prevalence, what's still in the bathtub, the mortality perhaps is what's leaking out. You could think of recovery as what's evaporating. There's also some recurrence. If you're thinking about acute disease, say impetigo, that's short-lived, it may be very hard to measure that because it comes in and comes out very quickly. Whereas a chronic disease may be easier to capture because it's in the bathtub for longer and you may be able to ascertain it when you do surveys or studies. But there's also a number of challenges to study episodic disease. So it's very important to differentiate disease activity from disease severity in this case. So here I give the example of a little patch of eczema on the eyelid. My husband has one. It doesn't bother him at all. It's always prevalent, but it's very mild. On the other hand, we all have had patients like this infant with very severe disease, but hopefully it improves and is not always active. There's also the hypothetical example. Let's say this is a patient with eczema. I'm going to use the term eczema and atopic dermatitis interchangeably for now. Let's imagine that this is a hypothetical example looking at severity and age, and just this dark band up here is when the patient has clinically apparent lesions on the skin. And by nature, it's episodic. There may be periods without time, days, weeks, months, even decades when they don't have clinically apparent disease. And if you were to measure disease incidence, this would be the true incidence when it passes into clinically apparent disease. But if you didn't have perfect capture from birth, you may only pick up when it becomes active out here, and you wouldn't truly know if it was incident. You may only be able to define it as newly active disease. Also, with episodic disease, if you were to do a big study and you went out and looked at everyone's skin, this patient, if you caught them on this day, may not be categorized as having eczema. Whereas if you asked them about symptoms over the last 6 months or a year, you would capture the period prevalence, which might be more relevant for a population. And we used to think that eczema mostly affected small children and improved with time. But as we've done a better job of measuring people of all ages, we can see there are very different clinical phenotypes by age of onset. And I think this emphasizes the point that regular, repeated assessments are needed to capture these patterns of disease activity over time. So moving on to think a little bit about data. The first category, large data category I want to introduce is what I'm calling bespoke research data. So any data collection designed to test a hypothesis, to answer a research question. This could be a survey, this could be a cohort study, this could even be clinical trial data. And it's wonderful because if it's well designed, it has the potential for very high validity. However, it may be more costly, it's often smaller or less generalizable, and by nature slower than using a routinely captured data source. So these are data sources that are not captured a priori for research. They could include electronic health records, billing or administrative claims data, surveillance data like cancer registries, or even disease registries if they're not designed to answer a specific question, although those fall closer on the continuum to bespoke research data. They're often cheaper, larger, faster, increasingly available, but they're of variable quality to answer the research questions people have. They're certainly prone to ascertainment bias because they weren't designed to collect the data we need. They're just have the data that happened to show up for whatever reason the person was there. And there are a lot of proxy outcomes, especially for dermatology, where, as I described, we often have disease categories, but not a lot of nuanced, detailed laboratory or quantitative information. So given that routinely captured data are increasingly available and for very large populations, it's important to know how accurate are incidence, prevalence, and burden estimates from routinely collected data. And oftentimes we're using international classification of disease codes to do this. I'm citing a review here from 2026 that looked at all the studies they could find that tried to identify dermatologic conditions. So they didn't specify prevalence versus incidence, but they found about 59 studies, and they found that the classification accuracy varied widely by condition and coding strategy, and that the highest performing algorithms often required two or more codes, dermatologist encounters, or they were combined with prescription or procedural data. So here's an example for acne. This is just one of the tables from their article. You can see here the positive predictive value. That's if the algorithm suggests a person has disease, the probability they actually have disease was very high from this one study. There was a range of sensitivity and also very high specificity. Here are some examples for cancer where they only have the positive predictive value, probably because they didn't have the denominator, only the reported cases. And you can see it varies. And again, this was one study. The point I want to emphasize is that as you add codes, the review found that the more codes you add, the better sensitivity and specificity oftentimes. So here's an example from psoriasis. This was a study that looked at psoriasis and Medicare claims data. And if you had just one 696.1 code, the prevalence would be 1.13%. But if you acquired people that have two codes, which is often the standard for these types of studies, the prevalence would drop to 6.62%. And if you require that code to be by a dermatologist, it would be even lower. So it's really important to remember that the validation studies where they exist are very important, but they're often designed to capture a subset of patients for a specific objective, and they may not always show how a more accurate code identifies only a subset of the population. This could dramatically affect the prevalence estimates. And as we add more codes, that means they're very likely to underestimate incidence and prevalence. Also, validated algorithms are lacking for many conditions, especially those in developing countries. Coding algorithms may not translate across context even within a country. They may be very specific to the database that you're looking at. And they rarely address disease severity or temporality, as I mentioned in the beginning, because those are much harder to capture in routinely captured data. So this emphasizes the importance of reporting. There's a broad spectrum and rapidly expanding set of routinely collected data sources, and it makes it challenging to identify the strengths and limitations and biases of each of these. So therefore, the way that we report our studies is very important. However, at least partially due to the trend for medical journals to publish things in shorter form as research letters, things are very poorly reported. But even in full publications, we see a lot of lacking data that allows the reader to assess how the database works and whether it may be appropriate for answering the question. So, a recent scoping review by a wonderful Australian dermatologist, Eugene Tan, that I was involved with, looked at the top 3 derm journals and studies using routinely captured data over the last 5 years, and found that even in full manuscripts, key transparency elements were frequently absent, and only less than half, 62%, had missing data, didn't mention the validation of their coding algorithms at all. And it's important to note that with both bespoke research data and routinely captured data, there could be missed estimates of the disease incidence and prevalence. Bespoke research data could have misclassification. For example, if you're doing a large population-based study, people may not be reporting as accurately as if you're in a clinical setting, or there may be limited generalizability if it's a smaller study. On the other hand, routinely captured data could estimate this classification for all the reasons I just talked about with the coding, or even let's assume we get the coding right. Not everyone is going to be able to make it into the provider, and limited access could also cause underestimation of the true incidence and prevalence of disease. And this is important because there's very large differences sometimes. In the case of eczema in the US, 10 to 20-fold difference between population-based estimates based on a national survey of self-reported physician diagnosis as compared to data from a large claims database where they required 2 of the ICD-10 codes. You can see the span is very large for both children and adults using data from the same year. And this is important for global disease burden estimates as well. Dr. Ong's going to talk to you about the global burden of disease in a minute, but I'll just highlight how important this is. There have been thousands of publications using global burden of disease data, and here are 3 that were published within the last 6 years that all used global burden of disease data. They're all from reputable investigator groups and good journals. But what's interesting, I'm showing the prevalence per 100,000 on the y-axis and the years spanning from 1990 up to about 2020. So the past 30 years, all 3 of these studies used the same data source, but had very different estimates. The first thought that the disease trend was fairly stable over the past 3 decades, but the most recent one suggested that the prevalence was 40% lower and decreasing over time. The one difference is that they use different iterations of global burden of disease data. And so they do a great job of constantly updating their estimates to try to make them better and incorporate new data sources. And so these 3 studies use different iterations of the global burden of disease data. And our hypothesis was that changes in the composition of the input data were causing the apparent decrease in historical estimates because of the way the models use Bayesian estimates to update missing or poorly captured data. And the nice thing about GBD is it's all publicly available, so you can go on their website and download the sources. And you can see that in 2017, only about 3% of the sources were routinely captured data. And in 2021, this had increased by about threefold. But there was an 18-fold increase in the sample size, representing 1.6 billion individuals from Russia, the US, UK, Poland, and Taiwan, all upper high-income countries. And our hypothesis is that these data sources, because they were so large, these 5 data sources swamped the models and caused very large changes in the estimates. And here you can see that, again, the GBD does a wonderful job of using Bayesian estimation that's necessarily complex to fill in the blanks. But even in 2021, there were still a lot of places that were lacking skin data, and primarily in Africa and Asia. So what implications does this have for the developing world? Here we combined or compared data from the International Study of Asthma and Allergies in Childhood, which in fact has a Guinness Book of World Record award that you can see if you visit Dr. Williams' office. It's been one of the largest epidemiologic studies ever performed. They went to over 200 schools around the world and used standardized assessments of allergic disease. And we compared that to the GBD estimates for the same age children from the same year, back in the early 2000s. And what we saw was that the Isaac estimates were consistently higher than the newest GBD estimates that included the routinely captured data. This is a Bland-Altman plot. On average, they're about 4% higher, but they were up to over 20% higher, especially in middle or low income countries, these blue dots as compared to the higher upper middle and the orange. And you can see the correlation coefficient was really poor, and it was worse for low as compared to high income countries. So I think that highlights part of why it's so important to understand the data source and how the estimates can affect the prevalence. And also, I want to emphasize the burden of dermatologic disease, because right now I've just been talking about prevalence. But to understand burden, we need to understand the impact on the quality of life. And I think this, again, is especially important for dermatologic conditions which have low mortality, but can cause pain, disfigurement, disability, stigma, and impact multiple facets of people's lives. And the impact varies by societal values, stigmatization, availability of treatment, and is likely underestimated in places with high stigma and low access to treatment. The good news is we can get some information from patients, and patient-reported outcome measures have been developed for a number of dermatologic diseases. I think they've come a long way, and they have an important role. There was a review from now 5 years ago, so we've made more progress, but it identified only 36 dermatologic specific patient-reported outcome measures, majority of which just looked at quality of life, and none of them met the consensus-based standards for recommendation for use. So there's still, that's not necessarily the status today, but there's still a lot to be done here. I think they're very important. So in my humble opinion, as a US-based dermatologist and epidemiologist, I think the path forward is that we need continued investment in new data collection. Although routinely collected data will continue to play an important role, I don't think it's the only thing that will matter going forward. We should still be designing bespoke studies. And when we do use routinely collected or captured data, we have to have validation studies that are done that include the frequency of code combinations so that we can see how the different sensitivity and specificity, the different algorithms also affect the disease prevalence. We need better reporting, less point-and-click epidemiology. We have to rely on our journals and our peer editors to help enforce that. We need the development of new ways to measure severity and burden over time. And ideally, if we can make those captured by the routinely collected data, it will be easier to access them in large populations. And then I would argue as a final point that we need better phenotyping and quantitative measures. And that may sound less exciting in the era of new technology and omics research, but I think it's essential for improving translational research. So if you think of the parable of blind men trying to describe an elephant, if they're all describing different parts, it's hard to understand a unified whole. Similarly, because we have these general categories of disease that we can categorize visually, these are examples from a derm textbook of atopic dermatitis or eczema, I think that limits progress even with more nuanced measures. So you can imagine that if you a lot of people differentiate between lesional and non-lesional skin if they're looking at molecular phenotyping, but they don't always specify whether it was a lichenified versus a oozy edematous lesion, how long the lesion had been there, where it was it on sun-exposed skin, when it was measured, what treatments, how bad, where the patient was in their disease trajectory, if they were coming on or off a flare. You can imagine there's a long list of things that the clinicians could help do to inform the basic scientists who are often performing the research. And sometimes those conversations don't happen. So I want to emphasize that translational research isn't just bench to bedside, it's a continuum, and collaboration is key. We need to talk to each other and reach across disciplines. And I think at the center of all of this is population health. So I want to thank everyone for their attention. I'll just mention my team and I will end there.
Katrina, thank you very much for that great talk. Um, we'll get some questions coming in, but can I just kick off? Your last point about the phenotyping is obviously very critical, but can I ask you what you think new developments in digital tools and the use of artificial intelligence, how do they improve or do they hinder disease surveillance?
I think, I mean, to give a general answer, as is true of a lot of AI, if used appropriately, it can help. I think that, it's again, like any of these new technologies, it's a chicken and egg problem. If you don't have a very clearly defined phenotype, it's harder to make progress. So the easy questions are, you know, if you're trying to differentiate, for example, eczema versus psoriasis, like in that first slide, you may be able to do that well. And that may be important in some settings, but the harder questions, I think, of trying to understand all the nuances of eczema phenotype, for example, um, if not done properly, I think you can get confused and it could hinder progress. That being said, if you that can be used to better refine the phenotypes and better refine the molecular research, it may be a step forward.
Okay, thank you. That's an interesting answer. We've got a question from Carsten here, if I can read it, which is, do you see a place for epidemiological methods being combined with omics approaches, and what area would you focus on? That is, of course, if you had sufficient funding.
Uh, that's a general question. I guess for me, I think that in thinking about this talk, I think having, again, not just a binary outcome for a lot of diseases would be really nice. If we could do more nuanced measures, or if you could imagine that if you have an omics panel and you have patients who cluster in one area versus another, I think that would help you better understand and predict uh, treatment response, disease trajectories. It may get us closer to sort of the personalized medicine that we haven't quite achieved with the current measures. So I would say that, again, understanding sort of the nuanced omics and pairing those to phenotype, but also the patient subjective experience. I think that's relevant to the first question as well. If you're trying to recapitulate something the patient can already tell you, sometimes it's nice to have that automated, but I'm not sure that takes us forward. I think we need to incorporate both. And we also need to be conscious of the fact that some of these new technologies or approaches may be important, but if they're too costly, they won't be widely generalizable. So there's always the goal of the fact that we could improve measurement of disease, but also make it more widely accessible.
Okay. Well, it's interesting because the next question is sort of again trying to explore that challenge, which is how much of the undercapture of AD in RCD is due to lack of specific coding by clinicians or the lack of patients seeking medical care for eczema?
Yeah.
tricky question. Yeah.
I, I think it depends a lot on the context. Even in wealthier countries, there's a lot of variability in the distribution of dermatologists. There are also a lot of incentives for clinicians to code things in a particular way. So a lot of patients are seen by generalists, but because they're reimbursed once they code a certain number of conditions, they may have their template where they put in sort of the general pediatric screening things, for example, and not there's less incentive to put in the code for atopic dermatitis. And I think that additionally, because we don't do a lot of lab tests, there are not additional reasons. Sometimes you have to pair those codes with tests, and we're not putting those things in. There's not diagnostic tests or lab tests that are needed. So I think that also impacts the undercoding. So it's a combination of things. There's a number of reasons why it may be undercoded from the clinician perspective. And then any disease is subject to the accessibility issues. I think diseases that require specialist care are probably even where there are specialists available for this are even more likely to be undercoded. And then for dermatologic diseases that are episodic or that can be managed with over-the-counter remedies, I think you lose even more of the mild disease that exists in the population. So there's, I think, at all levels, reasons why it might be underestimated.
Okay, thank you. And another question from Dr. Fuller. This is in relation to the World Health Organization's initiative on skin disease, and it's given the challenges shared with the problems of collecting data on skin disease surveillance and burdens, and the methodology isn't particularly robust and been present. What techniques or methods would you suggest we recommend to countries to use now on assessing disease burden uh, as recommended by the World Health Assembly resolution?
Yeah. I think there are ways to look at the subjective impact, and we should start there because that's an important piece of measuring the morbidity. In addition, although there are challenges, I highlight a lot of them for this audience. I didn't want to, hope to make it seem hopeless. A lot of these challenges pervade other specialties as well, and I think we need to start with what we have. I think that they're understanding if there are routinely captured data available, understanding how well codes perform in that context is incredibly important. And if there aren't, there's still a lot that can be done with surveys. People can self-report disease. So I don't think the limitations shouldn't be hindrances to doing it at all. I think it's important to document it and to include context-specific measures of disease burden where possible.
Okay, thank you. And we have another one, which is in the US and countries where there's different access to healthcare. Are there any strategies to help coming from the universities? So what role do universities have to play here?
Yes, I would love if the universities were receiving more research funding right now, but I do think that that's where the innovation can come from. And certainly digital tools have increased access in a lot of places. We do a lot of video visits that changed dramatically in the pandemic in the US and has continued, and I think improves access for people who are less resourced areas. Um, and certainly the universities in the US, their medical centers serve patients who are uninsured or who have uh, Medicaid and Medicare insurance that's often not accepted by private dermatologists. So I do think universities have an important role to play, both in terms of innovation and service. We're often the safety net hospitals. And unfortunately, that's very much needed nowadays.
Okay, thank you. Um, at the minute, we don't have to seem to have contact with Dr. Ong. So if you don't mind, if we can ask you a few more questions here. Um, so this is an interesting one about WHO data because um, there's a problem in data coming to the World Health Organization, which is that often the data's reports are late, they're inadequate, and so in a holistic manner, how does this affect strategic planning for health? In other words, the data is imperfect. If it's late, how do you deal with it?
I'm not sure I'm best poised to answer that question. I mean, I think that it's a Dr. Ong would be a good person to answer because they do a lot of work to deal with this at the Global Burden Disease Project. This is where some of the modeling comes into play, where you have to make assumptions and do the best you can and constantly improve. I think looking to similar contexts can be helpful, but as I highlighted, that it can also accentuate some of the issues, especially when I think you need to be very careful when there's very big data sources, because even small errors can, as I illustrated with the routinely captured data, can make a big impact. And I should say there were in the GBD project, they were adjusting. There was an adjustment factor, acknowledging that routinely captured data have lower prevalence estimates, but it was a single factor based off of US data that was applied internationally. And so it's a very complex process to do this. I have a lot of respect for the people who do. And it requires a lot of thoughtfulness when the data aren't perfect.
Yeah, it's a tricky one. My mentor in dermatoepidemiology, or rather in epidemiology, used to have a wonderful watchword, which was "There's nothing wrong with dirty data, providing you have a clean mind."
I like that.
Yeah, I like that. Um, Carsten, are we anywhere closer to being joined by Leanne?
No, sadly, it doesn't look like it. Serious apologies to everyone who's joined. We had a prep meeting with her last week on Thursday, and everything seemed to be well aligned. So I'm not sure why she hasn't joined us today. I'm very sorry about that. It would have been a really nice complimentary talk with Katrina's talking about the global burden of disease methodologies. Um, some of us have been working closely with them over the last few months on improving and changing the way they are doing their calculations. And Leanne was aware that this is a great audience to talk to because she and her team obviously need the dermatoepidemiology community to provide more robust data for their estimation. So I hope we'll have another opportunity another day as part of the GDEF seminar to then provide an opportunity to her to give the talk that was scheduled for today.
Yeah, I should add to that, Carsten, because over the last few months we've had very interesting discussions with the GBD team. Many years ago, I was the chair of the Derm Epi group that helped the original GBD um, team, which at the time were based in Harvard, and then halfway through they moved to Seattle. And there was a huge interaction between a group of dermatologists with an interest in Derm Epi and the GBD team. Leanne is brilliant. She's very aware of this and is trying to improve the liaison between dermatologists and the GBD team because it was something that worked very well. We could talk to each other, go back and forwards with questions, and that's beginning to start again. And I think she told Carsten and myself last week that she was going to take a critical view of the GBD effort and how they could improve it. But we should get some really good new data coming on atopic eczema fairly soon. And they're also going to work on scabies as well as two primary targets. Um, I don't know whether you want to add anything to that, Carsten.
No, I mean, I think it's great to see those changes within the GBD team, their recognition that some of their methodologies developed over the years need improving. And let's just invite her another time to discuss, the methodologies that they're taking forward. Really good to have a bigger forum of people to feed into that. Rod, shall we announce the next GDEF seminar then? And maybe Eleanor, if you can share the screen, that would be great. We've got another set of speakers lined up for you in a couple of months' time.
So our next meeting's going to be on the 27th of August, and we've got two speakers lined up. The first one is Dr. Sebastine Owo, who's based in Nigeria. He's one of the people who's been asking questions on this session. So he's a very active dermatologist with a great interest in dermatoepidemiology and health policy. And the other speaker is Professor Osmond Fay, who is currently based in the Regional Dermatology Training Center in Tanzania, but he's place where he's worked most is Mali, where he comes from, and he set up one of the early community dermatology programs in Mali. And so he has a lot of expertise in what he's going to talk about is leading from what the research question is to implementation in the field. So this should be a really good program. And I hope as many of you can join as possible. Unless anyone else has any other questions, we probably ought to end there. And again, sorry that we've been unable to have our second speaker on this occasion, but Katrina, you were brilliant, and thank you very much for your presentation and also for answering those difficult questions. Carsten, do you want to say anything else?
No, thank you, Rod, for chairing this seminar so well, and thank you all for coming. Really good to discuss what's so close to our hearts as dermatoepidemiologists. Thank you very much, all.
Bye, everyone, and thank you for coming.